Good afternoon, and thanks for joining me today. This is another webinar series in UCLA Health's medical webinar series. I am Dr. Jesse Nelson Mills, an associate professor, a clinical professor of urology, and the director of the UCLA Health Men's Clinic. Today, my subject I'm very, very excited about. This is something that brings me great joy and gratification as a physician, and that's because we're going to be talking today about second chances. And what I mean by that is we're going to be talking about vasectomy reversals and what I can do as a physician to help couples achieve pregnancy after the man has had a vasectomy. So before I begin in earnest, remember to hashtag any questions through Twitter at hashtag UCLAMDChat. And for that, at the end of the episode here, we will have some time for question and answers from the audience. So before I get into vasectomy reversals, we have to figure out how we got there in the first place. And so we're going to talk a little bit about vasectomy. And a little background on that is that a vasectomy is the easiest, probably most cost-effective way for couples to achieve permanent sterility or permanent inability to achieve pregnancy after a vasectomy. And so because it's so common, we have a lot of literature about this, and we have a lot of facts that I want to go over. Essentially, this is a very, very common procedure. It's also probably it is definitely less invasive, but also more cost-effective than female sterilization, as well as if a man is able to get a vasectomy and he's with the same partner, then the females don't have to go on oral contraceptives, and we don't have to worry about barrier protection for pregnancy prevention. So it's a very quick, easy operation, upwards of 15 to 20 minutes, outpatient procedure. So it makes sense for a lot of couples to elect for a vasectomy for their reproductive needs. Having said that, guys have a lot of questions surrounding vasectomy, and I'm happy to answer any of these at the end of the seminar as well. But one of the things that I get all the time is what happens to the sperm after a vasectomy. So the man continues to make sperm as if nothing changes after the vasectomy. In other words, a vasectomy, all it does is it closes that road. So that roadblock is in place, and every time a man ejaculates, the same amount of semen comes out, same amount of fluid, in other words, but he still does have that roadblock in his vasectomy. Now, the sperm get stored inside the testicle, and they don't go anywhere, which is fine. What happens after about 4 or 5 days is the sperm involute. In other words, the cells are made, the sperm are ready to go, and once they're ready to go, if they have no place to go, they just sort of shrivel up and die and get remodeled and come back to fight another day. So once that happens, if vasectomy is so common, upwards of 500,000 a year, and not all marriages end in happily ever after. So we have somewhere around a 30% divorce rate in this country. We used to think it was much higher. It's actually been on the decline over the last decade or so. But there are a lot of men that get vasectomies and then decide, for whatever reason, to have a reversal. So let's go over who that guy looks like and what that couple looks like. So change in female partner, as I alluded to. So a man and a woman marry, have children, they decide on vasectomy, and then something happens to the relationship, and now the man is with somebody else who would still like to have kids. So that's a very common scenario, but not exclusive by any means, and not necessarily the most common scenario. There are also men and women that decide on vasectomy for sterilization. They have 2 children and they decide they're done, and that little kid is so cute that they decide that they need to make a middle child and have another child. So therefore, I do plenty of vasectomy reversals on couples that have just decided to add to their roster. What about changes in religious status? So some religions, as we know, prohibit vasectomy as a form of birth control, and there are people and men that decide to convert later in life to those religions, and so certainly vasectomy reversal for religious preferences is also something I've performed over the years. Now, one of the things that we don't hear a lot about in vasectomy, but is a very important part of my practice, is there's a very small number of men that after their vasectomy end up with significant and often debilitating pain after the vasectomy. We're not exactly sure why that happens. It is probably something to do with obstruction of that the sperm fluid that causes this back pressure and pain, and why that doesn't happen to most men, we don't know, and why it happens to a very small percentage of men. Somewhere around 1 in 1,000 to 1 in 3,000 men after a vasectomy will have this pain. It's very, very significant. And so about, I'd say 8 to 10 to 12 times a year, I perform a vasectomy reversal purely because that man after his vasectomy is having pain. So the goals are different. Obviously, these couples are not trying to initiate pregnancies again, but what we're trying to do is relieve that blockage. And we'll get into how I do a vasectomy reversal in a few slides and have a little better understanding of that anatomy to understand why this could occur and then what I do to fix it. What about the men that have gone somewhere else for a vasectomy reversal and it didn't work? Are they still candidates for a redo vasectomy reversal? And the answer is absolutely, once I evaluate them, and we go into some of the evaluations necessary on the female side as well prior to electing vasectomy reversal as a way to establish fertility again. So here is the anatomy, at least, of the vas deferens and of the epididymis. And again, I'm going to turn towards my drawing here a little bit to show exactly where a vasectomy is done and then also where vasectomy reversals are performed. So the vas deferens itself starts really as this little tube that comes off the backside of the testicle and goes all the way up into the scrotum and eventually up into the urethra. So the actual vas deferens in a human is about this long. Where most men get vasectomies is the scrotum is somewhere from about here all the way down to here. So somewhere in here is the common site for an actual vasectomy. So when I'm planning my surgical case, I'm always visualizing exactly where that vasectomy site is, and that's the place I'm going to target first to find a way to put this man's vas deferens back together. And so vasal tube here, the other important gland I want to point out is this gland that looks like a little C called the epididymis, and the vas deferens is really merely a continuation of the epididymis. The other way to look at it is the epididymis is a very, very finely coiled tube. The diameter of the tubules of the epididymis is somewhere around 1/3 of a millimeter. As the epididymis stretches out into the vas deferens, the diameter of the inside of the vas deferens is somewhere around 1 millimeter. So you know that we're going to be discussing operating under a surgical microscope to even consider putting these structures back together appropriately and adequately. So epididymis is then attached to the testicle, and the sperm essentially made in the testicle and then through a series of ducts, these little very, very, very small tubes, is how the sperm get from the testicle into the epididymis and eventually along that tube all the way up into the urethra and the ejaculatory duct. They meet somebody who knocks them off their feet, and she in fact wants kids, and so they come see me. So prior paternity is important. If he hasn't had children, my workup and evaluation is slightly different. I want to know how healthy the man is, not only from what I think I might find impairments in sperm production, but also just his general health. And if there's any way I can intervene to make him healthier, that's probably going to make his sperm healthier as well. And ultimately, that's what I'm doing. I'm doctoring both the man and his sperm. I want to know what medications he's taking, because there are a few that have a significant impact on sperm production. So if you tuned in for my last webinar in male fertility, we had a little discussion about testosterone therapy, which is becoming increasingly more common, and sperm production, and it essentially completely shuts down sperm production. The tricky thing about testosterone is in this country, it's not a pill. It's most often put on as a salve or a gel, and a lot of men don't consider testosterone therapy medication. It's just something they put on in the morning. And that's critical for me, because if I don't ask that question, and I go in to do his surgery and put him back together and I don't find sperm, I don't know if he's not making sperm because he's got a genetic abnormality or whether he's on some medication that suppresses it. But the bottom line is, finding it out in the operating room is not the right time to find it out. Other critical factor, and this is something we'll touch on a little bit later as well, is how far out is the man from his vasectomy? Anybody that's done any research and reading about vasectomy reversals, that's the first thing that comes up in terms of predicting success rates. And we'll get into how important that is, but we'll also get into some of the reasons that that's relatively important as well. And that comes down to some of the surgical aspects that we're going to discuss later. But it is a general rule of importance that the longer a man is out from his vasectomy, potentially the chances of a successful reversal go down. But more important than that, it changes the surgical complexity. And that again speaks to the fact that if you're going to go through this procedure, you want to go with a physician that's very capable of performing whatever procedure you need in order to get the outcome that you'd like. On the female side, the age of a female is very, very important. Obviously, I want to know not only how old she is, but what her fertility potential is. In other words, does she have any medical conditions that may prohibit her from being able to achieve pregnancy? Because as great of a surgery as I can do to restore sperm to a man's ejaculate, if I'm not at least addressing the female side of this, I've done that couple no good. So I want to know her fertility potential, and I also want to know her patience level. And I don't mean this tongue-in-cheek. It's true that there is a difference in how I counsel couples based on when they want to get pregnant. And you'd be surprised, but not every couple that comes to see me says that they need to be pregnant in 2 months, 1 month, 6 months, 12 months. Most of my couples plan out their vasectomy reversal based on when they actually want to achieve pregnancy. But if a couple comes to me and they say that they really, really need to be pregnant in the next 2 or 3 months, we're going to have a very different conversation than if they are a little more patient with when they want to achieve pregnancy. And again, that circles back to the age of the female, because if a female is approaching the end of her childbearing potential years, then perhaps a vasectomy reversal is not the right procedure, and we'll talk about that in our alternative section coming up. So how do I counsel on success rates? And that's going to be the first question I'll guarantee, probably because I wrote it, but I'm sure it'll come through on the web as well, through our Twitter feed. What are your success rates, and how do I know if this is going to be successful? So one of the things that I say is time from vasectomy, as we discussed earlier, very important. But I will tell you that the reason that's important is because when I do the reversal, the first thing I do once I make my incision and I find where the vas was cut at the time of the vasectomy and I open up that tube, I look at the fluid coming out. And that fluid is going to teach me and tell me what operation I need to do and where I need to put that man's vas deferens back together. Because we grade our fluid based on the presence of sperm and the consistency of the fluid. And that's critical because what can happen in a man's sperm fluid over time is it can develop what we call inspissations, which is essentially where the fluid gets very, very thick, up to sometimes the consistency of, and I don't gross people out, but we do use the word toothpaste, and it looks just like you're squeezing a tube of toothpaste when that fluid comes out. That's not even fluid anymore. And the reason that's important is that if I saw that and I put that man's vas deferens back together perfectly, and I would come out and say, it was a great operation, I'm very happy with not only my surgical technique, but how things went, I have done nothing. I've done nothing to make that couple any more fertile than they were before their vasectomy. Because that fluid is so thick that body, the vas deferens, will never be able to push that out to get back to where the sperm really are. So if I see thick fluid that I know is unable to be ejaculated when I actually put this man back together, then that operation can't be done, and I have to go to a slightly different procedure, which we'll talk about. But when I do that slightly different procedure, success rates go down. So for me, a great day in the operating room, an easier day in the operating room is when I open up that vas deferens and I still see sperm. And if they're swimming, that's the best possible outcome. So if I see motile, swimming, happy sperm in the vas deferens at the time of the reversal, and most of the time, essentially 100% of the time, that man is going to have a good return of sperm to his ejaculate, and therefore the chances of pregnancy are going to skyrocket. If I get in and the fluid is clear or thin, and at least I'm seeing non-motile sperm, so they're there, they're just not swimming, that goes back to what we talked about a few slides back, in that just the time from the vasectomy is going to dictate often whether or not there's swimming sperm at the time of reversal, but I know that that man's going to be able to ejaculate out those non-motile sperm to get where the good swimmers are, and again, we'll be able to restore fertility. If I get in and I find sperm fragments, meaning I see heads of sperm and tails of sperm, this is just a timeline. So in other words, that just means that those fragments used to be sperm and they're on that pathway to complete reabsorption by the body. And again, it just changes how easily and how quickly sperm is going to return to that man's ejaculate. So quality of fluid is critical. So if I do a vasectomy reversal on a man that's 1 year out from his vasectomy and I find that paste, and I do a vasectomy reversal on a man that's 35 years out from his vasectomy and I find motile sperm, who do you think is going to have the best chances of success? It's the guy with motile sperm. It doesn't matter whether he was a year out or 35 years out. So again, that's why it's relative, the time to vasectomy. And there's a couple of things that we can do to predict whether or not I'm going to find motile sperm on that man. The two things that I look for on my physical exam when I see that man is I want to know where in the scrotum his vasectomy was done. We know that the higher up in the scrotum, the farther away from the testicle, the better the chances of finding good sperm at the time of reversal. That's number one. And number two is that there is a little scar tissue that we call a sperm granuloma, and it feels sometimes like a pea-sized nodule. Sometimes they can be as big as golf balls. But essentially, the presence of a granuloma in the scrotum on the vas deferens is also not quite 100%, but about as close to 100% predictive that we're going to find good sperm and good fluid at the time of a vasectomy reversal. So I can do that at the time of his initial consultation, which is why this is so important to get an evaluation ahead of time from your reversal surgeon. That physical exam is critical for he or she to give you the best chances of a successful prediction for outcomes of this procedure. So that's what the physical exam findings tell me. Experience of the surgeon, a shameless self-plug, but really you do want to go to somebody that has done hundreds, if not thousands, of these procedures and has done them well and has a good national reputation and makes a living doing this. In other words, the people that do this the best are the ones that are primarily dedicating their practice to microsurgery. So that's who you want to seek out. The other aspect to training for this is that it's not just about the surgery. It's also about the follow-up, and it's also about managing a man's hormones. And we'll talk about that a little bit towards the end as well. But very critical that not only am I doing my very best job possible in the operating room, I'm also managing that man's overall health in the post-op period as well as his hormones to make sure we're optimizing sperm production. Because we don't want to convert a man from an obstruction, which is what a vasectomy is, to a non-obstruction and not address any production issues as well, because the goal of this is optimization. We want to make this man as fertile as we possibly can make him and give that couple the best chance of achieving pregnancy. Follow-up is also important. So I like to see my couples back every 4 to 6 weeks until they achieve pregnancy because I want to follow his sperm counts. A lot of times what happens is that initial sperm count, when I see them around 6 weeks, I'll see some sperm, but they may not be completely optimal. And what I mean by that is they may be there, and they may be there in good concentration, but their motility, they may not be swimming really well. Or I might find under the microscope that their sperm are all stuck together, and that's something that I can fix with medications. And so we'll get into that a little bit as well, and I'm sure during the question and answer, someone will have a question about anti-sperm antibodies. So what is a procedure actually like? We're going to talk about preparation in one of the last slides. So what we're going to focus on is the duration. A guy wants to know exactly what I'm going to do with him most of the time. Some of my guys say, "Doc, I don't care what you do to me, knock me out, make me better, and tell me how it went." So for those guys, you may want to go grab a Coke and let your wives and partners hear what I'm going to say next, because we all will talk about the procedure itself. So usually the surgery takes anywhere from 2 to 3 hours, sometimes even a little bit longer. The goal of surgery, of course, is to do exactly as much as it takes to give that man the best possible outcome. So occasionally, if everything is very straightforward, I find sperm right away. I'm able to put his vas deferens back together, vas to vas, and do what's called a vasovasostomy, which is this procedure on top. That's about a 2-hour procedure. If I get to that point in the procedure that we talked about earlier, where I don't find sperm, I find that thick, pasty fluid in the vas deferens, then I have to do something entirely different. I have to do something called a vasoepididymostomy. What a vasoepididymostomy is also referred to as a vasal bypass, because essentially I am bypassing the vas deferens, where even though I find that the tissue looks good, if that fluid is so thick that I can't get around that to get to where I find sperm, I haven't done that man any good. So if you remember that drawing we had a few slides earlier, I'm essentially taking that vas deferens, going all the way around the obstructed vas and finding the epididymis where actually I can find sperm. And I'm plugging the vas deferens, a millimeter wide, remember, very tiny, into the epididymis, which is about 1/3 of a millimeter wide. And essentially, that is one of the most tricky things we do in microsurgery. And even if I do that perfectly, that's where we talk about discrepancies in success rates, is that a vasoepididymostomy, because you're sewing together tubes that are less than a millimeter wide, there's a chance that those tubes will never heal without scar. And even if there's a couple cell layers of scar, that may be enough to prevent a perfect outcome. Having said that, we still have good chances, and if we do this surgery enough and get good at it, then you should have very, very good chances, even with the vasoepididymostomy. Key is, again, surgeon selection. Make sure he or she is able to do that procedure before you sign up. So at the time of the surgery, it's done with a general anesthetic. Most men, I allow them to breathe on their own during the surgery. So in other words, my anesthesiologist is controlling their airway. They're comfortable on some intravenous sedation as well as a little bit of oxygen and an inhalational anesthetic. But they wake up very nicely at the end. I typically don't have to put them on a heavy, deep anesthesia. And again, after 2 or 3 hours, they wake up with 2 small incisions. My incisions are almost exactly the length of the man's testicle. So if a guy has big testicles, lucky him, but that incision is going to be larger. If his testicles are not as big, the incision is always going to be a little bit smaller. So that's as big as I need to make it to get in there and find the window I need to put that man's vas deferens back together. I usually have men abstain from showering for the day of the procedure. The next morning, they can get up, take all their dressings off, which is just a big fluffy wad of gauze. They get in the shower, no special wound care. Typically, I have them wear nice tight undergarments. I love the tight compression shorts better than the gym class jock straps that most people are comfortable with. But they work really well for keeping everything where I want them. And they do that for about a week. After about 2 weeks, I allow them to get back to full activity, including, yes, sexual intercourse. And this is good homework, but it's important for couples to actually ejaculate very frequently, because that's what helps wash out that sperm that is obstructed and not quite as happy swimming, and get to the guys that are being newly manufactured. So that frequent ejaculation is important. After about 6 weeks, I'll see them back in the office, unless I see them at that 2-week visit, especially if they're local here. But at 6 weeks is where I really want to see them, make sure that I'm happy with how the semen analysis looks, and make sure I don't have to do anything special with them based on that semen analysis finding. So, what if my first vasectomy reversal failed? This is not infrequent. Success rates of vasectomy reversals, people will quote anywhere from 50 to 98%. So that's a huge range. And it depends on the surgeon and it depends on the operation, as we talked about. But there's a lot of men I see on an annual basis that have gone elsewhere and didn't work. So we end up having to actually redo the procedure. Can I do it? Sure. Does it work? Sure. The technical considerations are different. So it's not always the same. Every time I do an operation, I'm prepared to do whatever operation it takes. But when a man has already had a reversal, I have to do 2 things. I have to find where that reversal site was and unblock that and usually bypass that. And then I have to get in and still look for where the fluid is and where the sperm are. And so the reason for that is, if a guy had a vasectomy and had his reversal, and at the time of his reversal, that surgeon did not evaluate that fluid quality and just did a simple vas to vas, that may be why it failed, as we talked about earlier. So I need to determine that before I move on and figure out exactly how to put this man back together. So I never quit the surgery. I never know exactly what I'm doing until I see sperm. And when I see that sperm and I know where it is, that's when I can plug that man back in and give him the best chances of a successful surgery. So, what if vasectomy reversal isn't the right operation? And why would that be? And there are a few reasons we alluded to earlier. Now we're going to get into it. So, a couple of things that I need to clarify is the only way for couples to achieve pregnancy after vasectomy is either a successful vasectomy reversal or a sperm extraction for in vitro fertilization, and that's the key. A question I get all the time is, can't I just aspirate sperm out and then use that for insemination or intrauterine insemination, this IUI? It doesn't work, and the reason it doesn't work is that we need millions of sperm for a successful IUI. If I'm doing a sperm aspiration, I'm happy if I get 1 million sperm, sometimes 2, sometimes more, but the bottom line is the minute I start aspirating sperm, I'm creating scar tissue in that man's epididymis, makes it very difficult to go back to that same spot or anywhere else and find sperm if that IUI didn't work the first time. So it's purely a matter of quantity. In order for an IUI to be successful, we need ejaculated sperm. So again, has to be done through either a vasectomy reversal or sperm extraction for IVF. That's the only way, or in vitro fertilization, the only way that we're going to be able to establish pregnancy after vasectomy. And again, if you tuned into my last webinar on fertility, if you didn't, welcome to go back and see it. It's still posted. But essentially, we talked about these different acronyms for sperm extraction. And after a vasectomy, the most common way most of us fertility specialists will get sperm for in vitro fertilization is through what's called a PESA, or a percutaneous epididymal sperm aspiration. The reason for that is we know what the guy's problem is. We know that he had a vasectomy, so we should be able to find sperm in the epididymis. So we take a small aspirating syringe and then take out as much sperm as we can from that epididymis, and we use that for IVF. A MESA is a little bit more involved. It's done through an incision and a surgical microscope, and that's if we're not finding a spot where we have adequate sperm, or for a surgeon's preference. Some of us just prefer to do everything under a microscope. If I get in and I'm doing a PESA or a MESA, and that sperm is not motile, it's too old, then I end up having to go back into the testicle. Same operation. Again, if I'm doing a sperm extraction, I don't leave the operating room or procedure room until I find sperm that's viable for in vitro. Then we'll do some of the testicular sperm extractions either, and again, most of the time at this point, I've made a tiny little window incision, and I'll be doing what's called a testicular sperm extraction. But you can also do that percutaneously or through a small puncture incision as well. And then lastly, I cannot see too many reasons why after a vasectomy a man would need a microsurgical testicular sperm extraction. We usually use that procedure for men where we don't know why they're not making sperm or their sperm quantities are so low. But again, that's the way we do sperm extraction. And so why would we do this? Why would I take business out of my own practice and say, let's do sperm extraction instead? It goes to the age of the female partner. So again, if that woman is towards the end of her fertility potential years, whether that's 34, whether that's 44, again, I would leave that evaluation up to the female's reproductive endocrinologist or OBGYN. That determines that they may have more of an imperative to get pregnant sooner than later. And if you look at vasectomy reversals and time to pregnancy, most of the time, it takes about 3 months to get good quality and good quantity of sperm back into the ejaculation after a vasectomy reversal, and it can take up to 18 months before we actually see pregnancies. So that's a wide window, and if that female partner doesn't have 18 months before she has her ovarian reserve depleted, then we need to think about something other than reversal up front. So that's why we have the discussion about sperm extraction in vitro fertilization at that first consultation. If a couple wants more than one child and they don't want to go through the IVF or in vitro fertilization process more than once due to expense or due to stress on the female partner or for whatever reason, vasectomy reversal, if successful, should remain successful. Should remain successful so that men can have multiple children after their reversal. So that's critical. There are couples that just do not want to have in vitro fertilization and want to do this spontaneously and naturally as much as possible, so they're going to be the best candidates for a vasectomy reversal. Now the expense, and that'll be another question I'm sure, and it's hard to nail down exact expenses for both IVF or vasectomy reversal because this is a medical procedure and every man is different and his needs may be different and there may be different tests that we have to do in order to look at suitability. But in general, globally, you can think of in vitro fertilization and sperm extraction to have a price tag somewhere in the $20,000 plus range. Whereas a vasectomy reversal, you can think globally is somewhere under $10,000. There's all kinds of variabilities, and it depends on what part of the country and what kind of surgeon you're going to. But remember those numbers, that in general, vasectomy reversal is more cost effective if it's the right operation for the right couple. What about success rates? Again, those are all over the place, and it's very difficult to quote both because each success rate has to be determined by the viability of both the male and the female partner, and that goes for either IVF or vasectomy reversal. So in general, we go back to that falling on the fact that if we're doing a vasovasostomy, so in other words, if I find that good quality fluid at the time of vasectomy reversal, then the success rates of getting sperm in the ejaculate are in the high 90% range. But again, that's only relative, right? Because if I do a great surgery and the man's got plenty of sperm in the ejaculate and they're not pregnant, to me that's not a successful outcome. And so the goal is follow up with your surgeon, follow up to make sure that we're finding out how to achieve your pregnancy goals outside of what happened in the operating room. And again, the recovery time, reversal versus sperm extraction, if I'm doing that percutaneous sperm aspiration, those guys are usually able to get back to work very quickly, less than a week before they can get back to normal activity, whereas a vasectomy reversal, as we talked about earlier, is more of a week-long process of healing and 2 weeks before they can resume completely normal activity. So how do you go about choosing a surgeon? Who do you want to see doing your vasectomy reversal if you've made that decision? So you want somebody that is fellowship trained. This is critical. The explosion of medical knowledge in this country over the last 30 years is so great, as is the explosion in surgical techniques, that you want somebody that truly specializes in whatever procedure that you're doing. It's very difficult these days to be somebody that has no post-surgical, post-residency training and doing such a highly specialized operation. So if you go to someone that's fellowship trained, you know not only they have the academic credentials to do the right workup, the appropriate workup, but also the surgical credentials to give you the best possible outcome. So ask. It's an easy question to ask. Make sure they're board certified urologists and get an idea for your comfort level with that person. You also want them to be knowledgeable in endocrinology. As we talked about, I can do a great operation, put a guy back together perfectly, but if I'm not managing his hormones that are responsible for sperm production, then he may not be getting the adequate care he needs. So you want somebody not only comfortable in the operating room, but comfortable in the exam room and the clinic to optimize your outcomes. You got to have somebody that's available and willing to follow up and willing to make sure they're going to go the extra mile to get you pregnant after that procedure. It's not just about the time in the operating room. Very important to have follow-up. And obviously somebody that does a lot of these and that has a good reputation both in the community and potentially nationwide. And then also getting back to making sure that you're not just going to a vasectomy reversal factory where everybody that walks in that has a vasectomy gets a reversal. Not good medicine, not what you should do. You should go to somebody that can counsel you and really give you the best possible procedure and best possible outcome diagnostics to get what you truly came into that office for, which is a pregnancy. All right, so now we're getting into preparation. What does a guy got to do to get into the operating room and have as best an outcome as possible? So if you smoke, stop. It's terrible. It's terrible for sperm. It's terrible for babies. It's terrible for everything. And that is your public service announcement on quitting smoking. Don't do it. If you exercise, keep doing it. I love it. I'm going to get questions about, is it okay for my husband to keep riding his bicycle? For the most part, bicycles and fertility are fine, unless you're riding 100 miles a day or 500 miles a week, and you're developing saddle numbness and difficulties achieving erections from penile numbness. For the most part, most of us recreational cyclists can keep on doing that, keep exercising. If you don't, start. Pretty easy. It's good for us, right? If you take any blood thinners, it does increase the complication rate, so I like to have my men stop about a week ahead of time, especially some of the newer agents that are antiplatelet blood thinners. Those are harder to test for. It does make the procedure a little bit more complex, complicated, and increases your risk of postoperative complications. All right, we actually got to the end of this webinar. I'd be delighted to answer questions. Again, hashtag UCLAMDChat for questions and for appointments to see one of the specialists at the men's clinic. The phone number is down here below to call and schedule your appointment. Looks like we already have some questions, so I'll grab the iPad and we'll start going. Okay, so here's a question. I like this question. Is it okay to get a vasectomy now and reverse it later? Sure. So that goes back into the, if a guy is pretty sure he doesn't want to have kids anytime soon, is it okay to get a vasectomy and then he can come back later to get it reversed? The answer is, of course it's okay. Is it 100% successful? No. And it goes back to what we just discussed. So if a man is comfortable with the fact that he has a reasonable chance of becoming a dad when he wants to become a dad later in life, then that's a perfectly appropriate route to take. However, I'm constantly counseling my men for vasectomy that they need to be really sure, because not only is it a bigger procedure to get it reversed, and because the success rates aren't anywhere near 100% for pregnancy outcomes, then he really needs to think about that. One of the other things that I discuss with my men that I counsel for vasectomies is consider banking sperm before your vasectomy. If you're not sure absolutely that you never want to have children, then spending a few $100 on sperm banking before your vasectomy is probably going to be the most cost-effective way to achieve fatherhood after vasectomy. Now, of course, the downside to that is that once you bank those sperm, they can only be used for insemination, IUI, or IVF, depending on how much you bank. And so that's going to be a discussion you're going to have with your future partner, that you've had a vasectomy. Good news, you've got sperm in the bank. Bad news is she's going to have to get pregnant through assisted reproductive techniques. As long as everybody's okay with that and they understand that, great. So I don't recommend getting a vasectomy unless that man is as close to 100% sure that he doesn't want to have children, not just because he thinks it's a reasonable way to have birth control up until the time that he wants to have children. That I don't recommend. So the second question I just answered, is sperm banking an option before vasectomy? Absolutely, highly recommend it. If there's even a shred of doubt, it's peace of mind and it will save you money in the long run. So another question that's come up recently is, and this actually went to bed and then came back again, what is the relationship between vasectomy and cancer risk? So there were some papers that were put out a long time ago that showed that there may be an increased risk of prostate cancer in men that have had vasectomy. Since that time, there's been a lot of research that shows that that's probably not, it's a statistical correlation, but not actually a causation, meaning that men that have had vasectomies tend to be more enfranchised in the medical community, and therefore they're getting screened on a higher percentage for prostate cancer. They most likely have already been to a urologist who did their vasectomy, and they're comfortable going back for prostate cancer screening, and that's why we see that blip. However, recently there have been some more studies that show that there actually may be a slight increased risk that is independent of just that one correlation. So we really don't know yet. There's certainly a lot of different options out there. A lot of different opinions out there, and I don't think we've got that complete answer. But there's nobody in any governing board or professional society that is recommending against vasectomy at this point because of a potential risk of increased cancer. So can I expand on sperm antibodies post-surgery, and how does it affect recovery times? So as we were talking about, the way that I get concerned about sperm antibodies is if I do a reversal on somebody and I'm looking at their semen analysis post-operatively and I see under the microscope that there are a few sperm that are happily swimming, and then there's a bunch of sperm that are all clumped together so that their sperm counts look good, but those sperms that are clumped together, they're clumped because they're sticky, and they're sticky often because they've had an antibody reaction from the man's serum that has gotten into their semen and sperm that has then made those sperm essentially non-viable. So the way that we treat anti-sperm antibodies is by looking for that first, minimizing that man's exposure to reactive oxygen species and free radicals, usually through anti-inflammatories, and then often through steroids, just like any antibody-mediated response or an immune system-mediated response, whether it's rheumatoid arthritis or whether it's a kidney transplant that we're trying to avoid rejection of, we use steroids. I do a short course, and that usually clears it up so that those antibodies are suppressed long enough for that couple to achieve pregnancy. So they're very important, but only in the context if they are impeding actual sperm release and sperm being able to do what they need to do. So important, but again, treatable most of the time. Let me see if we have any more questions coming in. So far, it looks like we're okay. So I think at this point, I really appreciate everybody's attention to this webinar on vasectomy reversal and fertility options after vasectomy. Thanks again for tuning in. And again, this will be up later on the UCLA Health website for replays, and appointment numbers down below. Feel free to call with any questions. Thanks very much.